Somewhere in your city, there's probably a hospital that people simply assume has always been there and always will be. It's easy to think of a hospital the way you think of a fire station or a library, a fixed piece of civic furniture, something government just provides. But a modern hospital isn't a building. It's closer to a small, self-sufficient city that has to run without a single second of downtime, and building one from scratch can cost more than an NFL stadium, take longer than most college students spend earning a degree, and still lose money every single year it operates. Here's the number that catches most people off guard. A single new hospital bed, just one bed, complete with its share of operating rooms, imaging equipment, and support infrastructure, now costs close to $2 million to build in the United States. A modest 200-bed community hospital can easily run past $200 million before a single patient walks through the door. So why does a building whose core purpose is simply to treat sick people cost as much as it does? If hospitals are meant to serve the public, why are so many of them, public and private alike, losing money? Hospitals may all look similar from the outside, but financially they're completely different businesses. Some are non-profit organizations, some are owned by investors, and others are funded by local governments. Yet despite those differences, they all face the same challenge: keeping one of the most expensive operations in modern society running 24 hours a day, 7 days a week. Hospitals are expensive because healthcare can't be delivered on demand like most businesses. A heart attack can't wait until tomorrow, so hospitals must keep staff, operating rooms, equipment, and emergency departments ready every hour of every day, even when many of those resources sit unused. That constant readiness is one of the biggest reasons healthcare costs so much. So what does it actually take to build one? Land acquisition alone can be a major obstacle, since hospitals need large, accessible sites with room for parking, ambulance access, and future expansion, often in dense urban areas where land is scarce and expensive. Once the site is secured, construction costs for a hospital in 2025 and 2026 typically run between $400 and $1,200 per square foot, several times the cost of a standard office building, because of the sheer density of specialized infrastructure packed into the walls. Medical gas lines delivering oxygen and anesthesia directly to patient rooms, redundant electrical systems, and backup generators capable of running the entire facility if the grid fails, advanced air filtration systems to prevent the spread of infection, and radiation shielding around imaging and treatment rooms. A basic 150-bed hospital can cost around $280 million to build, while large academic medical centers with more than 500 beds routinely cross the $500 million mark and can approach $1 billion once specialized units like trauma centers, cancer treatment facilities, and neonatal intensive care are included. And unlike an office tower or shopping mall, very few hospitals can simply write a check for projects this large. Most are financed through decades of borrowing, government funding, tax-exempt bonds, philanthropy, and future operating revenue, meaning many hospitals begin their lives carrying hundreds of millions of dollars in debt before treating their very first patient. Then comes the equipment. MRI scanners, CT machines, surgical robots, laboratory systems, and intensive care equipment can together cost hundreds of millions of dollars. Unlike buildings that may last half a century, medical technology becomes outdated surprisingly quickly, forcing hospitals into a constant cycle of upgrades simply to keep pace with modern standards of care. Even before opening, many hospitals must also navigate years of licensing, inspections, and regulatory approvals before they can treat their first patient. So where does the money to actually run this thing come from? You might assume hospitals make money every time a patient walks through the door. In reality, treating many patients actually costs hospitals more than they're paid to provide that care. That's because hospitals don't choose what most insurers and government programs will reimburse. They have to work within rates largely set by others. For public and nonprofit hospitals, the picture is genuinely complicated. Revenue comes primarily from a mix of patient billing through private insurance, Medicare for elderly patients, and Medicaid for low-income patients, but reimbursement rates vary enormously between these payers. Private insurance typically pays hospitals the most per service, Medicare pays less, and Medicaid often pays the least, sometimes below what it actually costs the hospital to deliver that care. This creates a system economists call cost shifting, where hospitals effectively charge privately insured patients more to help cover the shortfall from government-insured and uninsured patients, which is part of why hospital list prices can look so disconnected from what any individual patient's insurance actually pays. There's also a less obvious revenue stream that keeps many public and nonprofit hospitals financially viable: outpatient and specialty services, cardiac catheterization labs, outpatient surgery centers, imaging services, and cancer treatment programs, which tend to carry significantly higher profit margins than standard inpatient bed stays. In fact, many hospital systems today rely on these higher-margin specialty and outpatient lines to subsidize the money-losing core services, like emergency departments and inpatient psychiatric care, that they're nonetheless legally or ethically obligated to provide. On top of that, hospitals affiliated with universities can generate substantial revenue and reputation through research grants and clinical trials, while public hospitals often receive direct government subsidies, tax revenue, or disproportionate share payments specifically intended to offset the cost of treating uninsured patients. Operating a hospital, though, comes with expenses that are both massive and largely unavoidable. Staffing dominates the budget more than any other category, frequently accounting for 50 to 60% of total operating costs, because a hospital simply cannot function with fewer nurses, physicians, technicians, and support staff than a given patient census requires. Unlike a factory, you can't run a hospital with half the necessary nursing staff overnight without directly compromising patient safety, which means staffing levels are constrained by both regulation and basic clinical necessity, not just budget preference. Beyond salaries, hospitals face constant costs for pharmaceuticals and medical supplies, costs that have risen sharply in recent years due to drug pricing trends and supply chain disruptions. Utilities alone are a bigger burden than most people realize, since a hospital operating rooms and imaging suites require round-the-clock climate control, backup power systems, and enormous water and electricity consumption compared to almost any other type of commercial building. Then there's regulatory compliance, ongoing accreditation, infection control protocols, and extensive record-keeping requirements, along with malpractice insurance premiums that can run into the millions of dollars annually for a single hospital, a cost that has become one of the fastest-rising line items in the entire industry. So with billions invested, thousands of employees, and patients arriving every hour, you'd expect hospitals to be highly profitable. Surprisingly, many aren't. This is exactly why so many hospitals, despite treating enormous numbers of patients and generating substantial revenue, still operate on razor-thin margins or outright losses. Costs scale directly with patient volume and staffing regulations, revenue is capped by what government and insurance payers are willing to reimburse, and emergency departments, by federal law, must treat and stabilize anyone who walks in regardless of insurance status or ability to pay, turning emergency care into one of the most reliably money-losing departments in the entire building. When this financial balancing act fails, the consequences aren't just accounting problems. They can leave entire communities without emergency medical care. Nowhere is this financial fragility more visible than in rural America. Since 2010, more than 180 rural hospitals across the country have either closed entirely or been forced to eliminate inpatient care, and recent analysis has found that nearly half of all remaining rural hospitals are operating at a negative margin, with more than 400 considered vulnerable to closure in the near future. Labor and delivery units have been especially hard hit, with over 100 rural hospitals ending maternity services since the end of 2020 alone, largely because childbirth units require constant, expensive readiness, obstetricians, anesthesiologists, and specialized nursing staff on call around the clock, for patient volumes that in small rural communities may only justify a handful of deliveries a month. When a rural hospital closes, research has directly linked that loss to increased mortality in the surrounding county from conditions like heart disease, precisely because the difference between a nearby emergency department and one an hour away can be the difference between survival and death. Urban hospitals face a different but related risk: the financial disaster of a public health emergency overwhelming a system built for steady, predictable demand rather than sudden surges. The COVID-19 pandemic forced hospitals nationwide to cancel enormously profitable elective procedures, the exact services that normally subsidized less profitable emergency and critical care, while simultaneously driving up costs for staffing, personal protective equipment, and temporary surge capacity. Many hospitals that looked financially stable going into 2020 posted the worst operating margins in their history within a matter of months, a stark demonstration of just how thin the buffer really is between a hospital that's financially sustainable and one that's one crisis away from insolvency. Looking at what succeeds versus what fails in this industry tells a consistent story. Large academic medical centers and hospital systems that diversify across many service lines, subsidizing money-losing but essential departments with profitable specialty and outpatient services, tend to weather financial pressure far better than small, standalone facilities dependent on a single, unpredictable local patient base. Rural and safety net hospitals, which by mission and necessity serve populations with higher rates of Medicaid coverage and uninsured patients, operate with structurally thinner margins no matter how efficiently they're run, which is precisely why targeted government subsidies and programs like the Community Facilities Funding administered by the USDA have been shown to measurably improve rural hospital survival rates. Looking ahead, the hospital construction boom currently underway, with nearly 80 million square feet of new hospital space space under construction nationwide as of late 2025, valued at roughly $93 billion, reflects both genuine population growth and an aging population that will require dramatically more healthcare capacity over the coming decade. At the same time, technology is beginning to reshape where and how care is actually delivered. Telehealth, expanded rapidly during the pandemic, allows some outpatient consultations to happen without a physical hospital visit at all, potentially easing pressure on facility capacity even as demand for in-person, acute, and surgical care continues climbing. Artificial intelligence is increasingly used for diagnostic imaging analysis, predictive staffing models, and administrative efficiency, potentially helping hospitals manage their largest cost, labor, more precisely. And a growing shift toward outpatient and ambulatory surgical centers, which can perform many procedures at a fraction of a full hospital's overhead, is quietly pulling profitable, lower acuity procedures away from traditional hospital campuses, forcing hospital systems to rethink which services actually justify the cost of a full inpatient facility. So what's the honest answer to why hospitals cost what they cost, and why healthcare spending keeps climbing? A hospital succeeds financially when it can balance genuinely unprofitable but essential services, emergency care, trauma response, maternity units in low-volume areas, against a broad enough base of higher-margin specialty and outpatient care to cover the gap, and when government reimbursement and subsidy programs are calibrated closely enough to actual costs that hospitals aren't forced to choose between their mission and their solvency. It fails when that balance breaks down, when a rural facility's patient volume simply can't support the fixed cost of round-the-clock readiness, when reimbursement rates fall too far below actual cost of care, or when a crisis arrives that the system's thin margins were never built to absorb. A hospital isn't really priced like a business because it isn't allowed to behave like one. It has to be ready for the one emergency in 1,000 that never happens, and for the one that eventually does. That standing readiness, not the concrete or the MRI machines, is the real thing all that money is paying for.